a great human being and who has done some wonderful work in the field of a very rare disease. Most of you are familiar, but those who are not familiar, it's the field related to ocular tuberculosis, who has done clinical research, basic science research, the translational research in the field of this rare disease. And he brings in his experience, what he has done in last few years, and I'm amazed at the energy he's put in and the amount of work he has generated. I think simply amazing, and it will move the field of TB, ocular TB, forward in a big way. So, with that, I like to have Ivan, who is in Jakarta now, Indonesia, but having finished his PhD in Netherlands recently, speak to us. And I'm sure you will hear more from him in coming years, and you will be reading some of his amazing publications already in the literature. So, over to you, Ivan, to speak to some of the people who are on the thing, and I'm sure there will be more people who will be joining soon. Thank you so much for your time. Thank you.
Thank
Really.
you. Thank you, Rupesh, and thank you for inviting me to speak at this very beautiful lecture series. It's an honor for me to be here. So I'll start my slides here. I hope you can see. Yeah, is it now visible? Yeah.
Yes.
Okay. Thank you. So the topic is ocular TB. So I'm not really yeah, it's not like Dr. Rupesh. I'm still in the beginning of my career and journey. So, but I will try to a little bit explore and give some thoughts about the ocular TB based on the research that our group has already been doing for a couple of years. So, to start with, this is the outline of the presentation. So just a little bit of introduction. I know all of you, I think, already familiar with uveitis, and I'll just get in touch with the TB as an introduction, and then the current state of the management, the criteria and consensus, and the existing gap that I'm trying to delve into it based on the research that already been done so far, and some of the bit tips of the 10 clinical pros that can be applied to the clinics based on what we know so far and the future thoughts that maybe we can work together in the future. So I have no conflict of interest, and many of these materials that I present today comes from my PhD thesis entitled Ocular TB, and you can also access it online. I think it's already in the Erasmus library, or you can just simply use this shortened link. So uveitis, we all know that's intraocular inflammation, and the mainstay treatment is giving sufficient anti-inflammatory or immunosuppressive drugs, either locally or sometimes we give it systemic corticosteroids and even more immunosuppression. And we should think about the cause of uveitis and think about that it can be infectious, and we should prove it otherwise before doing treatment, just rely on anti-inflammatory drugs. And among infectious cause, TB is one of the interest. In Indonesia, this is our updated data that we try to just define based on groups, other cause of uveitis. So it's mixture of infection and non-infectious uveitis. And then from those that it's known to be uveitis with active systemic TB, and those with, we call it the interferon gamma release assay or IGRA positive based on a quantiferon test. And at the moment, this group give more than 50% that come to our center are already in the blind state, so less than 3-meter finger counting, and this is higher than those with other cause of uveitis, and it's can be explained by with the difficulties in doing complete screening, and then with the manifestations that not always typical, that I will elaborate more in this presentation. Starting with TB, we know that this is infection caused by bugs called Mycobacterium tuberculosis, mainly infect the lungs, and our immune system, especially macrophage, try to phagocytes and digest the bacteria, and eventually it will lead to the formation of structure called necrotizing granuloma, with the bacterium in the center core of the granuloma surrounded by T cells and also just very few B cells in the outside. So, and the macrophage will come close together, become a multinucleated giant cells. And this is a hallmark of the pathology for TB. And this focus of infection and the state of the patient can be completely cleared. So if it's already can be completely cleared without with adaptive immune systems, it can also completely clear just based on the macrophage function. And we call it the complete elimination with innate immune response. Sometimes it can also be in a complete state of elimination with the adaptive immune response being activated, or we call it latent TB. If it's still there, dormant, do not cause any symptoms and not progress to the clinically active disease. Or if it's so as a clinically active disease, it can be subclinical, very mild symptoms, or become completely active disease. So this is the spectrum of TB that can happen in our body. And how to test with TB infection if there is no symptoms? One of the tests is to stimulate our lymphocytes with the MTB antigen and see if there is a robust or increased interferon gamma using ELISA. And if it's so, then we know that there's a memory that our immune system already recognized MTB based on a prior exposure. So it cannot distinguish between recent or prior exposure. So once the infection began, and there is also a possibility that the bacteria escape and travel to distant sites hematogeneously and land in the eye, causing uveitis. And this is a very beautiful picture from patients with the cadaveric section showing choroidal granuloma. And it's beautifully see that it's only single or maybe two bacteria. So it's very possible bacillary infection in the eyes, in the back of the retina, and in this layer called retinal pigment epithelium. So in active uveitis, and we suspect as a manifestation of extrapulmonary TB, unfortunately, testing with ocular samples based on the ocular fluid give low diagnostic accuracy as the bacteria very few, cannot be cultured, and lay in the back of the eyes. So in the RPE, so getting the samples out of the eye in terms of ocular fluid, aqueous or vitreous, and test with PCR give low diagnostic accuracy. It's still an important part of the investigation, but it's not routinely performed. So what we can do is to find if any clue that direct toward active disease, then it's clear case that it should be treated with the complete or full course anti-tubercular treatment for at least 6 months. But many times there is no signs of active disease, only positive MAN2, so tuberculin skin test or IGRA. And we are still doubting whether ATT should be given or not, because we might think that it just past MTB exposure or declared, or there is MTB somewhere in our body that may be just latent, but then give some sort of activity in the eyes, or it's actually in the spectrum of mild or subclinical disease. Again, the IGRA positivity can happen in this 4 out of 5 possible spectrum of TB infection. And you can see that even in the complete elimination, we can still have a positive IGRA test. So this is the question for us. What if there is live MTB in the eye and with active uveitis, of course, with or without proven active infection in systemically? So we know that this is true ocular TB, but because we cannot do culture, not even sufficient bacteria that can be cultured, we often test with PCR. So PCR basically doesn't distinguish between just antigens or flying dead MTB or its live MTB, but we still believe that it should be positive or should be live MTB that causing active uveitis. So these two probably, yes, this is true infection. But what if there is no live MTB, no antigen, but we find something active disease somewhere in our body? Can it still be ocular TB? So this is the question for us. And what if there is no active disease in somewhere in body, but maybe there is somewhere latent or very dormant not necessarily adjacent to the eyes, maybe somewhere in a lymph node in our body. Can it cause active uveitis? And we still say ocular TB. And what if there is no live MTB, no antigen, and it's already completely clear and it causes active uveitis? And if so, should we call it still ocular TB? So this is theoretically can happen, but in the clinics, it's very difficult to distinguish these five. So which one necessitates ATT, and how we define which group the patients belong to, and can all these five scenarios give active uveitis? And based on codes, we know that the ocular inflammation consider TB based on ophthalmologists, based on tests, not necessarily based on histopathology or PCR. So we do screening, we do see active uveitis, and we believe that the uveitis caused by TB infection, whatever it gave live MTB in the eye or not, we call it ocular TB. So this is also intriguing that now the spectrum of or the thought is actually a new paradigm. Before we only knew latent and active disease. Now we have a spectrum of TB infection. And what's also interesting is this paper comes from the group Professor Russell van Gelder, in which this paper described the animal model. What this group did is to give MTB antigen or dead had killed MTB in a model with previous exposure to dead MTB and not. And what they've found is that the ocular inflammation, in this case panuveitis, more going to the chronic if it's already systemically primed. So there is no active infection in this case, only give the killed MTB and antigen, and once systemically primed, the second hit in the eye can cause chronic inflammation. So do we really see ocular TB, or this is the term that they postulate, post-infectious uveitis in terms of previous exposure? There is no live MTB here, but why this cause chronic panuveitis? So this is question for us. And recently, the group from Marion Mang described that there are similarities between the proteins in the eye and the bacterial protein. So this can mimic. So if our adaptive immune response recognize this bacterial protein somewhere in body, it may be possible that our T cells now carry a memory that can direct toward our ocular protein. And do we still call it ocular TB? Because this is just immune response, not live infection in the eye. So this is the question for us, and let's go through this. We are always doubting to give AT, and there is, of course, the balance between the benefit and the risk. If we give it, should be in a commitment at least 6 months, multiple pills, the risk of toxicity. But if we're not giving it, maybe this is really true infection and we miss it, and we can become worse with the disease course if we give only immunosuppression. So this is the timeline that I tried to simplify it in 2015. This is the classification intraocular TB. There are several clinical signs that stated here, and grouped based on the findings from the investigation, whether it's confirmed, probable, or possible. And in 2019, we have the COTS, and it's several years with a lot of publication. And there are several clinical manifestations that really get the consensus to start ATT if there are some combination. And eventually, this is a serpiginous-like choroiditis and choroidal tuberculoma, and active retinal vasculitis if it's something else, and the consensus is a bit weak. So, and also the group described the calculator, and with just clinical phenotype, endemicity, the test, which is Mantu, IGRA, and test X-ray, and there will be a score that can describe the consensus among experts. And it's already validated. And here we can see that because, as I understand, maybe Dr. Rupesh can clarify this later. This is based on the study sites that upload their case. So it's, for me, it's understandable that 95% sensitivity, because they thought that this is ocular TB, so they upload the case. And this is based on the 12-month ATT response, and you can see that specificity only 30%. When the COTS calculator gives score 4 or 5, there is a drop in sensitivity, but then increase in specificity. But still, there is quite some gap here when we move from COTS 4, COTS 5 here. There's quite far the drop, even though we increase the specificity. And also it's already validated somewhere else in the Indian cohort. And I think still the same, that COTS 4 probably can be applicable. And in 2022, we have the classification criteria, and this is the clinical manifestations, only 5 here. That's from quite some in the classification in the 2015, now only 5. And also combination with this investigation and exclusion. Importantly, sarcoidosis, and yeah, if it's doubting whether sarcoid or TB. So what I did during my PhD is a combination between the clinical cohorts, some wet labs and dry labs. I started with the see the clinical data from the patients from the Netherlands and Indonesia. We have quite some, more than 200 Indonesian cohort and almost 100 in Dutch cohort, that the attending uveitis specialists believe that it's directed toward TB origin. What we found is, of course, in Indonesian cohort, we see a lot of chest X-ray that quite suggestive for active TB, and based on the pulmonologist assessments, of course, more in the Indonesian cohort. And if we see the classification criteria and we divide the findings based on the SUN classification criteria, and those that do not fulfill this classification, it's only around 20 to 25%. And interestingly, recently, the paper from Proton Group published this month also describes around 15.9%. So it's more or less the same what we found and what somewhere outside the countries like Switzerland, Ethiopia's combination of different countries also find quite low proportion that fulfill this SUN classification criteria. So we also try to define or try to identify clinical manifestation if we just strictly go into the Indonesian cohort and divide those with active systemic TB and those without. Because before, what we see in the COTS consensus is the experts' opinion gathered together. But now we would like to see in our patient cohort ourselves what's the clinical manifestation that direct the active infection, that probably gives some clue. And here we confirm that the choroidal granuloma appear more in the direction of active infection. But if we pull this typical manifestation, still less than 50% that fulfill typical manifestation based on SUN criteria, which means that more than half of cases that actually proven to be active systemic TB present with the manifestation outside what stated in SUN criteria. So clinical manifestation alone is insufficient, although we confirm that choroidal granuloma should direct toward active infection and mandates starting ATT. So this is again the RPE that infected by the MTB, and it's already described in vitro study. And this is the former work from Dr. Rina that did the infection and tried to identify the pathways if our ocular cells infected with MTB. And this is just a picture, and see that in our RPE, if it's getting infection, it gives interferon signaling. So it's an innate sensing mechanism that activated once there's an active infection. So I continue to work with another cells, which is retinal endothelial cells. Why? Because not every granuloma happen in the choroid or adjacent to the choroid. See, this is a paper from the group of Dr. Basu with the retinal, they call it intraretinal tuberculosis, adjacent to the vasculitis. They see the granuloma, it's quite in the upper part, not in the lower part adjacent to the RPE, but here in intraretinally. So probably something's going on with these endothelial cells because it happened just adjacent to the vasculitis. So I infect the retinal endothelial cells. Now I introduce Hill-killed MTB because I see the group before with animal model, it gives some chronic panuveitis. So I try to see what happened with endothelial cells with this 3 treatment group infected with active TB, exposed to heat-killed MTB, or just control without any MTB. And macroscopically, the endothelial cells engulf the bacteria, whether it's heat-killed or it's live MTB. And even we see increased IL-6, IL-8 in those with heat-killed more than those with live MTB, but only those with live MTB give the robust IP10 response. Even intriguing when we do the gene expression analysis and we see that a lot of genes expressed in the live MTB, but not with heat-killed MTB. And again, when we do describe the pathway activation more in interferon signaling. And this give recruitment leukocytes, so it's in direction of recruiting more inflammatory cells toward the sites of infection, which is can explain why there is the granuloma adjacent to the vessels. And once we go into the patients, we do gene expression analysis from the whole blood samples, and clearly, based on the selective interferon inducible gene expression, we can stratify those with healthy. So this is starting with healthy patients and then active pulmonary TB, and clearly defined into 2 groups with highly expressed interferon inducible gene and those without, which is healthy controls. And here, when we apply to the quantiform positive angular uveitis, some give this response, which means the direction toward probability of active infection. And we postulate that those with this high gene expression might likely benefit with ATT. So again, this gives a translational study basis that what we find in the in vitro, what we find in the patients can give the identification of marker that can help distinguish those with active infection. So because we also curate the literature and found that serum protein C1q might also beneficial in stratifying patients with active pulmonary TB, then we applied this to those with uveitis, which we identify these markers is quite impressive in distinguish active TB. And when we stratify the patients here, we see combination with the interferon gene expression that I previously described, most of the healthy controls in these quadrants, but not the active pulmonary TB, so scattered in these 3 quadrants. And when we observe in this quantiferon positive uveitis, we see that some of those express high C1q, high interferon gene expression, which means these patients might likely be those with active infection. And recently we try to match with the Sun classification criteria. What we find also interesting, because those with proven active pulmonary TB likely either high C1q or high interferon gene expression, and very few that is low expression of both. When there is no active infection, but the clinically suggestive of ocular TB based on Sun classification criteria, we also see this high C1q or high interferon gene expression. When we see those that is not fulfilling any of these criteria nor active pulmonary TB, we see a lot of patients do not express high C1q or high interferon gene expression. But when we cumulate this, actually still more than half of our patient cohort probably in the direction of active infection. But what I would like to emphasize that we can give a benchmark or explanation why some classification criteria might likely high specificity, because when we apply this and match with the biomarkers we have, we see this high C1q or interferon gene expression in those without active disease but clinically suggestive of ocular TB. And also regarding the treatment, those in this either C1q or interferon gene expression score will likely benefit from ATT. So again, when we talk about clinical manifestation, there is similarities between sarcoid and TB, and we can see it with the criteria that compatible uveitic syndromes and those with TB and sarcoid, and need to exclude one another. And eventually, when I study in Netherlands, we see a completely different picture that in Indonesia, we have a lot of TB cases, in Netherlands, a lot of sarcoidosis, and even so, unlike I just realized that in India, actually a lot of sarcoid and a lot of TB here, but not in Indonesia, which very few sarcoid but high TB, and in Netherlands, which high sarcoid and very low TB. And this comes again with the paper from Dr. Rupesh that postulate the TB and sarcoid may be the opposite ends of the same disease spectrum. And interestingly, I try to analyze this serum proteomics in these two cohorts, sarcoid and TB. And what we identify is a lot of markers that quite similar between sarcoid and TB. And then we try to identify potential markers or pathway that direct toward sarcoid or TB. A lot of pathways that pop up for sarcoid, but not so much for TB. And I found difficult to identify which one that I can rely on for TB diagnostic here. But for sarcoid, I spot B cell activating factor that mostly directed towards sarcoid. So we start analyze the BAF, B cells activating factor, and find that it's highly elevated in sarcoid, just slightly in TB, but we can define a cutoff that might direct towards sarcoidosis and not TB. But there is no specific marker for ocular TB based on this Olling proteomics. So my dream is to identify marker for a TB, but I failed to identify one, but I can find marker that can discriminate sarcoid from TB, which is high serum BAF. So I take the markers that quite similar between both, and hopefully this marker should be low in other uveitis, which means the combination of markers of high serum CXCL9 here and BAF can lead to the diagnosis whether it's ocular sarcoid if it's both high, or if it's high serum CXCL9 but low BAF will direct to TB. If both become negative, then we can suspect something else. So I start with the validation with the serum biomarkers here, and eventually we confirm that this high BAF discriminates sarcoid to TB and two other uveitis with quite good area under the curve here. And when it comes to CXCL9, I also identify that this highly elevated in sarcoid, highly elevated in ocular TB, but not in other uveitis, which means confirm the previous hypothesis that the combination of these two markers can direct to the diagnostic of ocular sarcoid, ocular TB, or other uveitis. And again, when I try to match what happened with the previously described serum C1q and interferon gene expression, this CXCL9 eventually get a positive correlation with the C1q and interferon gene expression. So we can just use this marker to help the diagnostic. And when we stratify the patients with ocular TB, or quantiform positive uveitis, those with high CXCL9 would likely benefit from anti-tubercular treatment. So I postulate this schematic diagram, and it can be a early screening test to identify those with highly likelihood of sarcoid, those with ocular TB or something else. There's a question whether we can use serum soluble interleukin-2 receptors in TB uveitis. Is not clearly described, but it's mostly in the terms of sarcoid. What I identify is in TB, it's also elevated. So we have to be careful when interpreting these high soluble interleukin-2 receptors, because it's not only specific for sarcoid, it's also increased in TB. But when I try to identify the area under the curve, still combination of CXCL9 and BAF and not serum soluble interleukin-2 receptor will benefit the direction of ocular TB diagnostic. So in terms of the clinical manifestation, the granuloma here, there is a beautiful study that described that when we see specific pattern of granuloma in which we can identify the solitary granuloma, we can direct toward TB, where it's multiple will likely sarcoid granuloma. So again, this will be complementary one another. And how about the ATT? ATT, if because this biomarker is still in the preliminary phase, so how's the current state of giving ATT if we do not know what exactly going on in a patient? So this is the observation from the Netherlands cohort with those with IGRA positive or MANTU positive uveitis, and eventually, actually, in the beginning, we would like to shift the treatment to anti-TNF, but then it was decided to give ATT. What happened? Many of these patients get resolution of uveitis. So there's also possibility that it's clearly active infection that probably not being described as classical findings in the eye. So this is the review that we did a couple of years ago, try to combine everything with the treatment. It seems like there is a mixture what people diagnosed with ocular TB, and when we compile together, it's showing that the recurrence will be less if we give ATT. When I look back in our data from the Netherlands and Indonesia, what we identify when we analyze this retrospective data, we have to be careful because many of patients getting combination ATT and steroids will usually in the more severe presentation than those without ATT or those without combination treatment. So basically, what we identify in the systematic review before, probably there is underestimate the ATT efficacy, and we really need the randomized trial. So this is the randomized trial that we conducted recently in Indonesia. So we randomized the patients without active infection, with the clinical manifestation not suggestive of ocular TB, so just active uveitis, undifferentiated but positive IGRA. How if we give full course ADT, and how if we do not give full course ADT. Eventually, what we found is when we give full course ADT, it gives better resolution of uveitis and even give less recurrence of uveitis. So we, in our population, we believe that ATT full course might work in this patient spectrum at the current moment, in which there is no markers that clinically applicable at this time, but maybe we can refine this marker. So I just go through clinical pulse, what I've observed from my study into 10 pitfalls to avoid, that probably better to look just for our clinical daily basis purposes. So first is common pitfall is the inaccuracy of recognition of anatomical site of inflammation. Still, this is a very important first step to identify uveitis patients, even though we identify this typical and atypical manifestation still much higher than what we actually expected. So when we try to differentiate the patients into 3 groups now, not only active systemic TB and not only IGRA positive, but we introduce a group with positive PCR, we still identify those with typical manifestation likely direct toward active infection or proven MTB PCR. So if we find typical manifestation, we should really look and try to investigate robustly for active infection and don't miss it. I'll give an example of our patient here with the clearly see choroidal granuloma. There is no contact TB, there is no previous TB, there is no abnormalities from the chest X-ray, and even the IGRA test is negative. But when we see another investigation, it reveals positive PPD, TST, and also PCR. So we have to really delve into the investigation if we clearly see the typical manifestation. Again, this is another case with anterior uveitis with iris nodule. I just go through this quickly. And when we try to investigate the patients comes with TB lymphadenitis, which means that this is case of active systemic TB, and we should treat this with ATT. And number two is that assuming that ocular TB always present with typical manifestation, but it's not, because we find even with active systemic TB, still more than half present with atypical manifestation. So this is a patient from the Netherlands that she's still in the in Dutch language. So I just try to point out that the patient with a fever and then headache, and there is no findings in the eye that point towards ocular TB. And eventually the IGRA test become positive. And long story short, the patient diagnosed with active meningitis due to TB. So what I can conclude myself is any patients with typical manifestation should promptly evaluated for active TB, while those with atypical presentation does not necessarily rule out active disease. So we still have to do complete workup in our patient. And three, of course, as a clinician, we have closely look at the patients. Sometimes it's just clinical diagnosis that can guide the management, like toxo, sometimes with HLL-B27 associated anterior uveitis, VKH, BCHATS can be feasible based on the clinical findings. And in our cohort, we believe that doing chest X-ray will be benefit, because 14 out of 16 patients that proven to be active systemic TB comes to the ophthalmologist first before going to the internal medicine or pulmonologist. So we have to be careful and do complete workup for our uveitis patient. And again, regarding the IGRA test, it's clearly stated that the negative IGRA does not rule out TB. As I described before, case with choroidal granuloma, IGRA can be negative, but then we find PCR to be positive. Just go quickly. Why IGRA become negative even though with active disease is still unclear why, but there is a hypothesis that maybe compartmentalization of T cells in the sites of infection, because we only get the samples of the peripheral blood. It's not enough to get those with high expressing T cells with interferon gamma. And assuming that the molecular testing for TB has no additional diagnostic value, as I mentioned before, it's not routinely performed, but still in the Sun paper, it's reasonably diagnosed ocular TB with PCR. And what we identified in our cohort is also in the direction what Sun described, high specificity, but low sensitivity. And when we try to match with the treatment based on this meta-analysis, what we identify is some group can get very high yield of PCR, eventually supporting the first notion that those with these patterns of suggestive ocular TB manifestation, when we test with PCR, will increase the likelihood of PCR positivity. And in our cohort, interestingly, we identified those with exudative retinal detachment that tested positive for PCR. So what is this actually? And in this, based on our cohort, we identify several clues or several patients that maybe benefit from testing with PCR. Those with the absence of systemic TB despite clinical manifestation that typical for ocular TB, those in our population with some sporadic cases with exudative retinal detachment warrant doing PCR, and those with inconclusive TB immunoreactivity tests, maybe because of previously treated TB or it's not really known what's the result. Sometimes it comes with indeterminate result and we can test with PCR. Again, it's described in our population that exudative retinal detachment may be linked to ocular TB, and it also described somewhere else. But this case beautifully show with the ultrasound that can describe the granuloma. So I think ultrasound may be beneficial in this exudative retinal detachment to see if any granuloma underneath the detached retina. Number 6 is the hesitation to initiate ATT. Based on what we recently described, that ATT works even in patients with uveitis of undifferentiated clinically, but tested positive for IGRA. And it's also aligned with what described in the rheumatology guideline. Those with the patient with high likelihood of receiving prolonged immunosuppression should be screened for TB at the beginning. And in terms of treatment, they say that it should be guided by national guideline. But what we identified in our population, it should be treated fully with full course ATT. So again, the question is, who will go chronic, who will have relapse? We identified several markers that increase the likelihood of having chronic uveitis, patients with intense anterior chamber inflammation at presentation, those with choroidal lesion, and those with retinal vasculitis, even though there is no active infection somewhere in the body, but tested positive for IGRA, in our population, it will be benefit to give ATT in the first place. And because when we don't treat it and then the patient get a poor response after 6 months, then the patient will go more in the chronic phase. Then 7, the follow-up, I'm not a big fan of giving trial ATT, even especially in those with choroidal lesions, because we can see the paradoxical reactions and we can confuse if we just rely our diagnosis based on the trial ATT. So we have to continue along with the treatment until it's finished. It's already described here what happens if we see worsening of inflammation as part of paradoxical reaction in ocular TB, and what should we do as a clinician. Eventually, it should improve or increase the immunosuppression or steroid treatment. And again, with the relapse cases, we should not just discontinue follow-up once it's completely treated. In some of the patients, it can have a relapse. And what I observe in the Netherlands population, that the relapse mostly in the anterior uveitis and can just effectively manage with topical steroids and not necessarily repeating anti-tubercular therapy. But we do not know exactly in our population in Indonesia. And 8 is we do not increase the dose of immunosuppression in terms of corticosteroids, because actually rifampicin will decrease the plasma level of the steroid. So the actual steroid may be not enough to control the inflammation. So consider to increase the dose if we combine ATT with steroids. And it's also interesting to see that most of the papers described with oral steroids, most of them did not adjust for the dose of steroids. Only one paper here that described can give 1.5 milligram per kg per day, which should be increased because of rifampicin decrease the level of steroids. And macular edema can happen sometimes in ocular TB, and those with macular edema will have less visual acuity. And who will develop macular edema? We know that it's older age, existing diabetes and retinal vasculitis will have likelihood of having macular edema. And what I observe in the Netherlands, they can try to give acetazolamide as an option to give better pump function in the RPE to help clear the water content. And it's not so much study describe the use of carbonic anhydrase like acetazolamide, but based on what we try to review the current literature, it seems to be a feasible option for those, especially with steroid responders, and then not completely quiet with steroids, and this can also be helpful in some cases. And number 10 is repeating IGRA testing for no reason. If we do not suspect any reinfection, I think doing IGRA testing in terms of relapse cases will have no benefit. And again, this is just a summary what I've told you about the 10 clinical pros that can be adopted in the clinics based on what I observe when I doing the research. And just give a short future thoughts on this topic, because I see in our Indonesian and also in Netherlands population that there is not so much serpiginous-like choroiditis that we observe. But this is quite intriguing because in Indian counterparts, they see a lot of TB serpiginous-like choroiditis, more than 100, even 300 cases here. So what even in those with negative TB immunoreactivity test can have this SLC. We rarely see this phenotype in our Indonesian, despite Indonesia and India become the leading TB burden. Is this the host response that differ, or we actually see different MTB strains that affecting different geographical area? As we know that TB is not just a single bug, it's actually have several lineages that can have different immune response when infect the human cells. So probably this also underlie the differences in the clinical manifestation, particularly in the serpiginous-like choroiditis observed in my research. And again, this lineage affect ethnicity. So probably there is a link between host and pathogen response here with different MTB lineage that should be explored more in the direction of ocular TB. And one of the tools that we try to develop to study this is by giving a shot to start doing experiments with iPSC-derived RPE cells, when we can get the RPE from multiple different clinical manifestation, different ethnicity, and try to see if the response are different. So we are now working with this, and hopefully we can elaborate more or explore more about the host response in ocular TB. And lastly, I just want to give about the retinal vasculitis. This is quite interesting. And when we see retinal vasculitis, this group described there are three in B, and then focal tortuosity, like you can see here, also in the FA, and occlusive vasculitis. But also, I raise a question whether the vasculitis can happen really because of direct infection in endothelial cells, or is actually bring by the phagocytes or lymphocytes in the retina and give the inflammation to the adjacent vessels, or it's actually the response from other cells in the eye that the inflammation go into the vessels and leak the cellular, the intravascular component, or maybe the TB is not in the eye but somewhere else in the body and give response as in terms of hypersensitivity reaction and give the small vessel or small vasculitis that happen in the eye. Whatever it happened, I think once we know that there is infection in our body based on the markers, we can give the ATT. And lastly, this is just my thoughts about moving forward with criteria. I just get the view from the rheumatoid arthritis, in which initially they measured the rheumatoid factor as one of the criteria. They then refine the criteria and give more emphasis on the biomarker here with the antibody, anti-citrullinated protein antibody, which they introduced into the system. And now they also questioning whether it's time to revise the criteria again and try to see more details in terms of biomarkers. So I think in the future, ocular TB really needs the biomarker in the criteria so that we can try to solve the problem with the current criteria, which more in the direction toward clinical manifestation, and we can delve and put more biomarkers that supposed to be the direction of active infection. So lastly, because we are talking about TB, we now to give ATT or immunosuppression, we should also think maybe we can give somewhere else to boost the immune mechanism to combat TB. And this is a paper that I describe about how to boost our cells based on findings that currently happening, not in ocular TB, but in systemic TB, that we can extrapolate to ocular TB. So we can give another modalities, try to get the inflammation resolve as soon as possible. So I would like to give thanks to all of the supervisors during my research and the Indonesian colleagues in the Netherlands. As you can see, this is when I finished my PhD among those with the uh, committees, the Prof. Mark de Smet and Joke de Boer, and also a lot of insights from the Prof. Shali and Dr. Rupesh. And I also would like to thank to Prof. Martin Jagger and Prof. John Forrester that gave me credit with the cum laude or distinction with my PhD. So thank you. I'm sorry if it's already over time, but I hope it raised a great discussion and we can move forward. Happy if any questions arise. Thank you.
I think, Ivan, this was a simply amazing talk, and you opened up so many nice questions, and probably, and you answered some of the questions as you that. I really like the way you thought about it, the way you presented. You came up with a question, then you try to answer, and open up quite a lot of those. And this is how, for the younger people who are on this call, how research should be done in a particular, very focused way, and then going deep and deep. I think that's one part. Of course, we can continue to talk about ocular TB, but I want, if anyone in the audience want to unmute themselves and ask any questions to Dr. Ivan, please feel free to do so. Anything related to research or particularly in the topic of ocular TB, any comments or anything you want to kind of say? Irina, you want to say something about Ivan's work and your work?
Hello, hi, Dr. Rupesh. I'm sorry, I'm
Yeah.
turning on my video. Thank you so much for letting Iwan to present in this very lovely meeting tonight. And we are already experiencing so many benefits from participating in Proton. And I think this is a very important group that gathered the data from not only Asia, but all over the world. And also, Iwan here is continuing my work. We're still looking for the right biomarker for ocular TB. And I think from you also, you already developed COTS and also the imaging for TB. Hopefully, we are going to the direction of multiple biomarker, not only from the blood, but also the clinical manifestation from COTS study group, and then also from the ocular imaging. I think this would come nicely at the end, and we can probably getting closer on really diagnosing ocular TB, Dr. Rupesh. I think this is a very concerting effort, all of us together. So I think there are a lot of ophthalmologists from Indonesia also coming in this session. I think I also like to encourage everybody to participate in collaborating in studies like this. I think that's only my comment, Dr. Rupesh. Thank you so much.
Thank you so much, Dr. Rina, for giving Ivan to the world of scientific literature. I think this is your hard work, and then how Ivan has responded the best way. I think this is a true quality of a mentor. And we have invited, therefore, mentee to speak, not the real mentor. I'm sure we'll have Rina also one day. But thank you, Dr. Rina. And anyone else? Any comments? Any questions to Dr. Ivan, Dr. Rina, and to Dr. Rina? Anyone from the team? Please feel free. Professor Alexandra, always thanks for joining the call and always grateful to you. If you want to say some comment about Ivan, is like very much like Carlos and William, so super motivated.
Thank you for this fantastic talk, Iwan, and it's a very important topic that we continue to learn about. Thank you, Dr. Rupesh, for allowing us to be part of Proton.
Thank you so much. Thank you so much.
Thank you.
Really appreciate. So, if there are no questions, we would like to thank Ivan for spending a time with the team Proton and giving your valuable insights about the research and your journey and about the topic of Ocular TV. I think this will be made available on the video on the Proton Lecture Series. So, we have recorded and hopefully more people can listen and they might like to reach out to you. We'll connect you with that thing. And at the same time, I want to thank all the speakers for taking out time on Friday evening. I know it's a time to enjoy party and all on the weekend is started. So I think, but despite that, you people are here with us listening to this topic. I think thank you for the wonderful audience and particularly the friends from Indonesia. You all joined. I think this is very grateful and very heartening. And my young team of Proton team members here in Singapore, Rachel and Hans and everyone there, otherwise there I can see. So I think thank you all of you for joining and really appreciate. We look forward for again continuing with the